First set of revisions changed that to ISO 7 air in the clean room, and you can see what the standards are there for ISO 7 air. Generally, you can achieve ISO 8 air without HEPA filtration, but it's impossible to achieve ISO 7 air without HEPA filtration. So with those standards in place, a lot of people are having to step back and look at their facilities. The other interesting thing about the ISO standards is that they mandate a positive pressure environment in the clean room. And that's created a lot of problems for us in oncology compounding, because we all know that for hazardous medications, you don't want positive pressure. I mean, if you do have any contamination, you don't want that blowing out of your clean room into the rest of your pharmacy. So that was in direct contrast to the NIOSH report, and also to some current published standards that deal with gene therapy as well as with radioactive drugs that indicate we should be compounding those in a negative pressure environment. USP 797 in the first set of revisions actually recognized that, and they had a statement that said, well, yeah, we know that's a problem and we're working on it. Didn't really tell us what we were supposed to do, but in the recent revisions that came out last month, they made a very clear statement about this. What they said was, for compounding hazardous medications, we should have a separate clean room. So you can't compound anything in that clean room other than hazardous medications. So if you're making your TPNs, that has to be done in one room. You're making your chemos, that has to be done in another clean room. It should be ISO class 7, and it should have negative pressure. And they define negative pressure as a room that's lower pressure compared to adjacent spaces. And therefore the net flow of air is into the room. So that's a big change for us. I don't know how many of you have a clean room just for chemotherapy, but we certainly don't. And I don't really know of too many people that do. So that would be a major investment for all of us to go out and build clean rooms just for our hazardous med compounding. It's also not real easy from an air handling perspective unless you spec those systems out when you first build a room to go from positive pressure to negative pressure. And the other interesting thing is, where the anti-rooms were spec'd out at ISO 8 air, if you have an ISO 7 negative pressure clean room, you also have to have an ISO 7 anti-room, because the air quality that you're pulling into that negative pressure room has to be the same. So again, that's going to require some major facility design and renovation, because if you don't have HEPA filtration, if you've got sinks, if you've got all that kind of stuff in your anti-room, you're going to have to change that in order to be able to hit ISO 7 air. So again, that's something to really pay close attention to, because that's going to mean some major renovation for us as well. And that's pretty consistent, though, with the European standards. When you look at Europe, they're probably about 10 years ahead of us in terms of their application of some of these safety standards. In Europe, they already all have specific areas that are just reserved for compounding hazardous medications. And they actually use GMP Class A air, which is the same as our ISO 7 air. And they require a negative pressure room for hazardous medications. So they've already done this over there for about the last 10 years. Another big question that I see out there is barrier isolators. Is this an alternative for us? I see a lot of organizations investing in barrier isolators as an alternative to the USP 797 clean room standards. Certainly, I think we know that barrier isolators are an alternative to biological safety cabinets, or your vertical flow hoods. But the big question when USP 797 and NIOSH came out was they really didn't tell us what we were supposed to do with these isolators. They didn't tell us what type of isolator. There's compounding isolators, there's aseptic isolators, there's compounding aseptic isolators, there's positive pressure isolators, there's negative pressure isolators, there's turbulent flow isolators, there's unidirectional flow isolators, and then where do you put them if you buy one? Do you have to put it in the clean room? Or can you just drop it out in a hallway, since it's all self-contained? And that's what a lot of people were actually doing. They were taking the isolators and they were just putting them in a separate room, not necessarily their clean room. And because the isolator was all self-contained, in the first iteration of USP, it actually met the standards. And then there was a big question about, personal protective equipment. Well, if I'm working in an isolator, do I need to glove, gown, mask, do all of the same personal protective standards that I would do if I was working in the biological safety cabinet? And the answer to that one is actually, yes, you do. Unless you can get a written certificate based on valid testing from the manufacturer of your isolator that says specific elements of personal protective equipment are not required. And I don't know of any isolator manufacturer out there that's actually done that or is providing that documentation. USP 797 in the first set of revisions actually said that a well-designed positive pressure barrier isolator is acceptable as a replacement for conventional laminar airflow workbenches in clean rooms for aseptic processing. So that really didn't tell us very much. And they also went on to say that you can use an isolator, just make sure you're using it according to the manufacturer's recommendation, which was kind of a big cop-out, since most of the isolators were not were not originally designed specifically for healthcare. There really wasn't too much out there. So there was still a lot of confusion, but in these most recent set of revisions that came out last month, USP again, I think, did a good job in clearly defining what their expectations are for us. So they said if you're going to get an isolator, it has to be a compounding aseptic isolator. It has to be capable of producing an ISO 5 environment in the working area, and it has to be 100% vented to the outside. And then as far as where you put it, they've also said that preferably it should be put in that ISO 7 negative pressure clean room. But if you don't put it in there, it at least has to be in a dedicated room that's negative pressure and has a minimum of 12 air exchanges per hour. So either way, you're going to have it in a separate room, and you're not just going to be able to drop it out in a hallway anymore. They also go on to say that if you do put it in the separate room, the onus is kind of back on the manufacturer and back on you, because you got to be able to demonstrate that in conditions that are less than ISO 7, that barrier isolator can still maintain ISO 5 conditions when you're loading it and unloading it. So it's probably the safest alternative is probably just put it in the clean room. It's interesting, in the United Kingdom, they've used isolators for probably 20 years. Isolators and biological safety cabinets are pretty interchangeable over there. But what I was really surprised about in Europe is they don't actually recommend isolators at all. When you read the European quality standards, that last statement is a direct quote from their quality standards, and it says it's common knowledge that the apparently greater safety provided by an isolator is achieved at the expense of considerable handling difficulties in operation. And under these circumstances, hardly any operator will opt for an isolator. So the pharmacists and the technicians that I talked to from 9 different European countries, no one was actually using them. And that's probably a little bit closer to what we see in U.S. practice. We're just kind of exploring them. They're not really the standard of practice over here yet. Biological safety cabinets similarly weren't that well defined in USP 797 and NIOSH when they first came out. And what's interesting is, there's 3 different types of biological safety cabinets: Class 1, Class 2, and Class 3. And within Class 2, there's actually 4 different types. And the difference between A1, A2, B1, and B2 is based on airflow, whether or not it recirculates air with clean air, whether it's vented to the outside, and whether or not the plenums, when they're dirty, are actually contained in a negative pressure environment. So the type 2, B2, the answer to all 4 of those is actually yes, it does all of those. So if you're looking at purchasing a biological safety cabinet, you want to look at a Class 2 type B2. Class 1 is basically just a fume hood. It protects the operator from the product, but it doesn't keep the product sterile. And Class 3 is completely enclosed, and that's essentially an isolator. And what's interesting is when I go out and survey, and I'll go into the IV center and I'll ask the technicians and the pharmacists, well, what kind of biological safety cabinet do you have? And they'll say, I have a vertical flow hood. What kind? Most of them don't know. They don't know if they're working in the correct kind of hood or not. So it's something to check when you go back to work. What kind do you actually have? You should have at least a type 2. And that's, again, it's very consistent with the European standards. They recommend a type H, which corresponds to our Class 2. They also suggest that that be vented to the outside. The USP revisions actually have taken a good position. They say that we should have Class 2 or Class 3 biological safety cabinets. They have to be capable of producing an ISO 5 environment, and they also have to be 100% vented to the outside. And that's, again, a big thing, because for a lot of facilities, You know, the pharmacy may be in the basement. You don't have an outside wall. So how do you tie that into the ventilation system?